My name is Sanjay Gupta. I'm a consultant cardiologist in York, and today I wanted to do a little video on the subject of blood thinning medications for patients with atrial fibrillation. Now, I am currently in Vienna, and I'm attending a conference on the subject of Afib, or atrial fibrillation. And the conference is, during the conference, a lot was talked about blood thinning medications. The first thing to say is Afib, or atrial fibrillation, is a condition where the heart starts beating irregularly. When the heart beats irregularly, it pumps less blood out compared to when it beats regularly. Because it is pumping less blood out, that means some blood doesn't get pumped out of the heart. And because that blood isn't getting pumped out of the heart, it doesn't move as much, and therefore it can stagnate and form a blood clot. And then there is a risk that bits of that blood clot could get dislodged and go to the brain and cause a stroke. And we know that the risk of stroke in atrial fibrillation is greatly increased. And therefore, it is generally recommended for the majority of patients that they go on blood thinning medication to try and reduce this risk of clot forming, and therefore the risk of that stroke from happening. And most patients with Afib are then faced with the dilemma of going on to blood thinning medication. And when they go on to blood thinning medication, they have to do so for life. The problem with blood thinning medication is that it thins the blood. That's how it works. But because it thins the blood, it can cause bleeding. And one of the big concerns patients have is, if I go on this blood thinning medication, what happens if I start bleeding? I could bleed torrentially, and there is obviously a very real risk of dying because of bleeding. The bleeding is not common, but it is nevertheless a risk. So until very recently, there was only really one agent that would thin blood effectively, and that was warfarin. A lot of people recognize that as rat poison. And what would happen is the patient would be put on warfarin. The warfarin works by thinning the blood, but you have to measure how thin the blood is and titrate the dose of the warfarin according to the thinness of the blood. Now, that is called an INR, and a lot of people who are on warfarin have to go every week or every 2 weeks and have a blood test. And based on that blood test, that warfarin level is adjusted. For a lot of people, that's a big hassle because it means recurrent blood tests, and it means recurrent visits to the hospital. It is also true to say that it takes quite a long time before you can get within that range. So the INR has to be between 2 and 3. Okay, and when you start giving the warfarin, it takes a little bit of time to get between 2 and 3. And you're only protected by adequate thinning of the blood when the INR is between 2 to 3. So when the INR is not or hasn't reached that level, the patient is still not protected against the risk of stroke. I did a little study once upon a time to see how long it took for patients to get their INR between 2 to 3. And I calculated that it takes an average of 35 days from the day you start warfarin to the time where the INR reaches that therapeutic range. So for about 35 days, the patient is still at risk. Now, the risk is not great, but there is nevertheless a risk. And the truth is that you're taking a tablet which isn't protecting you for almost 35 days when you first start taking it. It's also true to say that the majority of patients would require about 11 blood tests between the time that they start the medication to the time that they reach within that therapeutic range of 2 to 3. So for a lot of people, warfarin, although it represented the only choice to thin the blood, it also represented a major hassle. Then came along these new agents called the NOACs, okay? And the big thing about the NOACs was that they were marketed as an agent where that monitoring was not required. And so they're now available, widespread. They're available all over the world. They're certainly available in the UK and the USA. There are currently 4 NOACs in the market. These include dabigatran or Pradaxa, which was the first NOAC that was produced. Then there is something called rivaroxaban. Then there is apixaban. And finally, there's a new one called edoxaban. Okay. And the advantage, obviously, with all of these is that they don't require monitoring. And thereby, you just take a tablet or as per the dose, and you don't require any blood tests on a routine basis to see whether the blood is thin or not. There is enough data from clinical studies showing that if you take the tablet on a regular basis, the blood thins as it would with warfarin. So that's one of the obvious advantages. The second advantage is that they start working immediately. So you don't have to wait for 35 days or an average of 35 days before the drug is achieving its most potent effects. The medications start working from the day that you start taking them. So that's an obvious advantage. Now, what has happened is more recently, the National Institute of Clinical Excellence, NICE, in the UK, have said in their latest guidelines that patients should be given a choice as to which agent they would want to choose, which agent they would like to take. In the past, the problem was patients were not being given a choice because there is a lot of political pressure, and because it is perceived that the new agents are more expensive, and therefore if everyone goes on the newer agent, it would break the budget set out by the government, and there was a lot of political pressure not to be prescribing these agents. However, NICE, the National Institute of Clinical Excellence, in 2014 turned around and said, well, actually, we acknowledge that these are great drugs and all patients should be given a choice. Now, I did a little study again in my practice, and I looked at patients who were in Afib and in whom I recommended that they go on blood thinning medication. And I would normally write to the general practitioner and say, dear sir, this patient has Afib. I think they need to be on blood thinning medication. Could you meet with the patient, discuss the various different blood thinning medications, i.e. warfarin and all the other NOACs, and prescribe something that they choose, that the patient chooses. And what I would find is that more than 60% of the patients would come back on warfarin. And so my question to myself was, well, why are so many people choosing warfarin? I know if it were me, I would choose one of the NOACs. I would choose one of the newer agents. So why are so many people coming back on warfarin? And that's something that I didn't understand, because surely if those patients were being told what I know, or what we know as a medical body, then why wouldn't they choose something that we wouldn't choose for ourselves? And so I did a little study where I asked patients after they came back to say, well, why did you choose warfarin? You know, what was your main reason? Is it something that your doctor's not telling you, or is it something that you're not telling your doctor about, you know, your concerns about the newer agents? And what I discovered was that the majority of people were told about all agents. However, they were put off by the fact that the new agents did not have an antidote, i.e., if they started bleeding, then there was no way to reverse the bleeding. And the only the advantage they remembered of the NOAC was simply that with the new agent, they didn't require the blood tests. So that was an advantage, but the obvious disadvantage, which outweighed the advantage, was the fact that with the new agent, there was no antidote, and this would lead the patient to choose warfarin. Having said that, the truth is, when you look at the studies, and even when you read the NICE guidance, it is well documented that the NOACs tend to cause less bleeding, particularly in the brain, compared to warfarin. So it's important to realize this, that when you think about bleeding, there are two major places where a person can bleed from, okay? Where you can sustain a life-threatening bleed from if you are on a blood-thinning medication. The first is the head. You can bleed into the head, and that can cause, a threat to your life. And secondly is within the gastrointestinal tract or the gut, and that can also cause a major life-threatening bleed. However, there is a distinct difference between these two organ systems. The gut is accessible. Someone can easily access the gut by putting a scope down the throat or up the back passage, and you can access the gut. And if you can identify where there's bleeding, you can do something about it very quickly. The second thing is you need to bleed quite a lot from the gut for it to become life-threatening. The brain is slightly different. In the brain, you only need to bleed a tiny amount before you die from it. And secondly, the brain is not easily accessible, i.e., you can't access the bleeding point very quickly as a doctor. When you look at all the studies, this is a consistent feature. The NOACs, the new agents, cause less bleeding in the head compared to warfarin, all right? That's the first thing to say. So I would rather, in my own mind, take something I'm less likely to bleed with than take something that I'm more likely to bleed with. The second thing to say is that if you are unlucky enough to have a bleed in the head, then having an antidote is not going to make a huge difference, because you only need a small amount of blood. And if you're unfortunate enough, you would die from that. And therefore, having an antidote in a hospital doesn't really serve your purpose. You bleed in the head, you're unfortunate enough, that's it. If you're able to get to a hospital, then in all likelihood your bleed wasn't ever going to kill you anyway. So this whole notion that there is no antidote is a wrong one, simply because you would much rather, it's like two things. You can either cross a bridge that you are more likely to fall off, and if you fell off and you survive, there's an ambulance waiting to take you to hospital, or cross a bridge that you're less likely to fall off in the first place. The second thing to say is it is not true anymore to say there is no antidote. For a agent called dabigatran, the first one on the market, there is now a reversal agent which works immediately as soon as it's given. Okay, so you start bleeding if you're in hospital and this drug is given to you, it will work within 20 minutes. So what I'm trying to get across with this is that if it were me, if I had atrial fibrillation, I would definitely choose a NOAC over warfarin any day of the week, all right? And I think ultimately it doesn't really matter what you take as long as your anticoagulation is good. As long as your blood is nice and thin, that's the most important thing. But if someone offered me the two choices, I would much rather take something like a NOAC, not because of the less monitoring. Of course, that is a real advantage, but more importantly, because it is safer for me to take the NOAC compared to warfarin. All right. So I hope this was helpful. My problem really with this is that a lot of people are not being given the right information and therefore end up choosing warfarin. You take the NOAC because the NOAC causes less bleeding in the head compared to warfarin and gives you a more persistent, quicker onset of action and better anticoagulation control, which is more convenient compared to warfarin. So I hope this was helpful. And thank you for listening. You can contact me on, let me just tell you, this is me. And this is my website and my Facebook page. And this is my secretary, Jeanette's number. So I hope this was helpful to you. Thank you so much for listening, and all the best.